So that leads us really well into our panel discussion. I'm hoping the folks from the panel can turn their cameras on. I'd like to take a moment to introduce just the folks that you haven't yet heard from. Johnny Morris is the CEO of. First, I want to say that as I read each of these folks' bios, I realize that they're all particularly modest. I know them well enough to say that they understate who they are and what they've done. Johnny Morris is the CEO of Canadian Mental Health Association in the BC division. He's been a strong leader and advocate, pushing for more inclusive and empathetic approach to mental health in Canada. He's played a crucial part in shaping the new provincial portfolio of Ministry of Mental Health and Addictions, and he currently leads the CMHA BC. I guess my conversations with Johnny around this have gone on for a number of years, and this understanding that a community-based approach, a whole population approach that supports is really the best way to support mental health as well as other issues in our community. Really looking forward to speaking with Johnny. Dr. Baldev Sanghera, who many of you may know, has been a leader in this work in Burnaby, certainly since I've been around, and I also know for much longer than that. He's one of the founding directors of Primecare, and also the medical director of the Urgent and Primary Care Center. And he's been here since 1990. He's been a key founding member of the Division of Family Practice, and he also now sits on the Family Practice Services Committee, one of the joint collaborative committees of health in BC. Dr. Josh Greggain he's the president of Doctors of BC, which is the association of the Physicians Association in BC. But I think more than that, Josh has taken a leading role in rural health across the province for many years, and also I'm going to be asking him specifically around some of the work that he's done in the Hope and the region there that has really focused on similar approaches here. He's been instrumental in really driving some of the great work that's happened in that region. And Dr. Ray Markham he's a family physician as well in Valemount, and the executive director of the Rural Coordination Center of BC. And as well, he's been a leader in rural health in many other ways. He was a founding member of the Division of Family, the Northern Interior Division, Interior Rural Division of Family Practice. I should remember that because it's NERD, and has been just a passion. He's passionate about rural medicine, and he really has been a driver in some of these same kind of conversations around how community is such a critical part of the picture of health and well-being, and how to create integration. And we have so much to learn from rural. So I'm really excited to have Ray here with the input that he can bring. So really great panel. Just for panel folks, I'm going to sort of be asking you direct questions, but I'm hoping that if you others have thoughts, then you'll put your hand up, or you'll wave, or you'll scream at me, because I really want to make sure that we do catch everybody. And maybe we can start a little bit locally here, and just from a primary care, from a physician point of view. Well, maybe I can look at you. Can you talk just a little bit about the value you've already seen for your patients in Burnaby through the way that this integration has worked to date within the PCN?
Absolutely. Thanks, Jeff. First of all, I really want to thank Dr. Helen Kingston, Jenny Hartnoll, and Katie Mulligan for their presentations. Highly inspiring, and it lifts all of us to do better and continue the work that we've started on. So thank you. And I really want to also acknowledge the privilege that I have of being here and to serve our community. So what I've been able to see from my position in Burnaby with all of the integration work that's been done is certainly seeing how our collaborative approach to addressing social issues has helped me in my office, because often, in some cases, I'm the only connection that some of our, especially seniors and new immigrants, have in Burnaby. Right? There is no other family or friends yet to support them if they're newcomers, and sometimes the seniors, that they're the only ones left of their social network. The rest of the network has passed on, or younger family members have moved away. And so I'm sort of, checking in on them on a social basis, checking their blood pressure, seeing how they're doing. But that's not enough. They need more. So our um, ability to engage with our social agencies and community services, as well as through the health authority, has been wonderful in connecting them. As an example, we have a seniors connections pilot that we've been looking at through Burnaby Neighborhood House. Kimberly is the lead on that one. And the purpose of that is to promote social connectivity and reduce social isolation, and to provide access to a broader support programs for my patients. Also, for me, it gives me an extra set of eyes on my seniors. The volunteers are connecting with the seniors to have a cup of coffee or tea with them, go do their shopping for them, and bring connection back. Initially, in early stages of when we were studying the system, the healthcare system and community, I've been engaged with the City of Burnaby's staff now for about 15 to 20 years in various different volunteer roles. We found that only 65% of the population felt connected back to the community and back to their neighbors, which is pretty low. In order to have a robust community, we want it to be much higher than that. So this allows us to do that, and we, as a physician, through our integrated work, we have access to a broad team of allied health workers who are deployed by Fraser Health into our neighborhoods to support our collective patients. Another example that I can give you is our response to COVID in 2020, early 2020, when everybody else was floundering. We as a collective got together and said, no, we can't. We need to support our community. We need to protect our hospital. We need to protect the doctor's offices. We didn't have any PPE, protective equipment to protect our human resources to serve our patients. And so within a 2.5-week period, connecting in with our municipal leaders, we had set up a drive-through field hospital within Central Park, which was then a model for the rest of BC to follow, and to serve the community. We ended up serving over 110,000 people within a year. To do that in 2.5 weeks, it's pretty impressive. And the degree of collaboration that we had was all coming through a sense of trust that we had built, social capital that we had built in the past. We even had physicians going out onto to shelters to do house calls to homeless people who would never have gotten access to services and care. We had pharmacies donating samples of medications to those people who could not afford the medications in those shelters. And so we really looked at how, in an equitable fashion, how can we deliver the services in the best way possible? What we found was that by looking at these targeted populations, we found ways to support everybody else as well. So that's been a big key learning for me is, yes, we have these wonderful integrated programs that then target the services to vulnerable populations, but we need to, at least the physician side, it's much easier for us to look at how can we support those needs for the broader population, because unless you talk to people, well-dressed people also have social problems that need to be served. And so I shouldn't have to, dig into somebody's file, and because I'm not going to find the information there. We don't collect that data. We should, but we don't collect that demographic data or that social data in order to prescribe care in a better way. So that's where I'm coming from, Jeff. We have been able to serve a community in other ways. I remember you and I, we did a seminar on COVID and access to vaccines. We were running a Zoom seminar, and simultaneously translating into 7 different languages and having a question and answer session back and forth, not just one way, it was a two-way communication in 7 different languages. It's fantastic. We can do this if we choose to.
Thank you. It's interesting. Someone put in, I think I mentioned earlier that I thought that I quoted 60 and I said languages spoken in Burnaby, and I'd heard numbers of 90, and someone pointed out in the chat that a recent report showed there are 120 different languages spoken in Burnaby. So it's really quite astounding. I want to just go to there's a premise that we take in building this model that really points to what Baldev was speaking to. This whole population approach, rather than targeting services, targeting social prescribing, targeting connection, targeting supports to specific vulnerable populations. We take a whole population approach which better serves those specific populations and also addresses the broader population. Johnny, I'm wondering if you can speak to that. I know you and I have spoken a little bit, just the value of a system-based this whole population approach as it relates to mental health.
Well, thank you, Jeff. A great honor to be here on such an esteemed panel, and very grateful to Dr. Kingston, Jenny, and Dr. Mulligan earlier for all that they've shared. It's fantastic, and it is, as Baldev said, inspiring to be parts of these dialogues. I'm very grateful to be here in unceded Tsleil-Waututh, Musqueam, and Squamish territories, and very grateful to be here, the privilege to speak. And for those of you who don't know CMHA as well, I represent the provincial office, and locally you have a very strong branch there in Vancouver, Fraser, who's doing some very neat integrated work around primary care and employment right now with funding that we have from the province. Your question is really important, Jeff, and I think Dr. Mulligan spoke to this in the comments around proportionate universality, which is a concept that we've held close here at BC Division around when you're targeting whole populations and you're allowing things to catch up, particularly when you're applying a social determinants lens, whilst doing targeted things, around folks living with mental health and substance use problems. You can start to see the changes that we want to see. And I think, as I've listened in on the presentations and the panels this morning, what all of this work reminds me of is that we still have such a road to go around parity of esteem. This notion that our mental health and our substance use related health is incredibly integrated with our physical health. And we still live in this paradigm of profound disconnect. And so we forget that someone who's hearing voices or perhaps experiencing hallucinations or living with psychosis or schizophrenia also has a heart that might be challenged with heart disease, or the physical health implications of the medications they're taking have profound physical impacts whilst also treating the mental health side of things. And the UK, and having been actually in Frome recently for other reasons, it's lovely to just hear how far along they are, and I think there's lots to learn from the UK in really driving this whole of system approach around care, which really starts to enshrine the right. We all have this right to good mental health, and the expectation that you're going to get just the same level of quality of care when you're receiving physical health care as you are when you're presenting with mental health care. And I know the pendulum has swung backwards and forwards around, do we disaggregate, do we aggregate, do we link up? I mean, at the end of the day, we're whole human beings. And I think to what Dr. Sanghera was saying a moment ago, we all experience, better care when we're treated as whole human beings. So, we're really excited about this, and we're a unique mental health organization in that we're not disorder specific. We're lifespan focused, and in the heart of what we do is a very public health orientated, social determinants driven. Like, we really believe that mental health starts where you live and where you learn and where you play and where you love and where you work. And to detach mental health and physical health care from those settings, really does leave us further entrenched in a fairly significant crisis in this country when it comes to mental health and substance use care. So I have a very strong relationship to hope when I hear what's happening in Burnaby. And I think when you combine these principles, we're going to start to see people living with low mood experience better physical health. We're going to see people who are experiencing loneliness receive care more quickly. We're going to see likely, and I think this was a comment made earlier, lives saved, because people who are experiencing profound hopelessness, perhaps contemplating taking their own lives, are going to connect to conditions that actually enable living. Like, all of this is about structuring conditions that enable more livable lives, which really at its heart is pretty amazing suicide prevention. So yeah, that's what I would kind of have to say to kick it off, Jeff. Thanks for that beautiful question.
Thank you, Johnny. And I actually want to go to Helen. And Helen, I know that you know that this is part of what your purpose design was, basically taking this whole population system-based approach. Can you talk a little bit, sort of in retrospect, about how that has served your community, how you've seen it work, and also maybe how it's served you as a physician?
I think it's really important to take that whole population approach to make it much easier for people to access those services. There is often a little bit of stigma attached to this is a service for this particular cohort. So being able to say, this is going to make you feel better, this will help you with your life, without having to link that to the challenges that someone might have, makes it much easier for people to engage with those services. And I think that's been really key in helping to persuade people to change and supporting them to do that, that they're not having to come and say, I'm vulnerable, I'm not managing, we're trying to move everybody to a better place. So you can come as you are and focus on trying to move to a better place without having to say first, I'm not coping, there's a problem. Because that's hard for us all as human beings to take that step. So let's make it easier for people to engage.
And from your perspective as a physician, how has it changed your world to be able to have taken this broader approach?
I think the real difference that we have as clinicians now is that when you've got somebody in front of you, you're able to have a conversation about what's going on in their whole life, in the knowledge that if you happen to delve into their sofa surfing, their drug use, their difficult relationships, and then most people will have a support network within their own family and friends, but if you probe into that and they have absolutely nothing there, we now have a framework to be able to continue that conversation and offer them support. And it isn't that everybody with a problem in life needs professionalized support, but that safety net of knowing that if we have someone in front of us, we have those conversations about what's really going on in their lives, and they say, I've got nothing, I've got nobody, I'm just got nowhere to turn, then we do have that framework to be able to move that conversation forward in a positive way, rather than just open up a can of worms and then shrug our shoulders and say, well, you can have this pill, or, well, I haven't got anything else I can do about your problems. So it's much easier for everybody to engage in that human interaction about what's going on.
So do you feel somewhat more supported as a clinician then?
I feel much more supported. I feel much more empowered to begin those difficult conversations and let them flow in the way that matters to that person, because I've got that safety net that if we get to a dreadful point and they've got nothing, that there is that structure that I've got to rely on to go back to be able to make some suggestions for them and offer some support.
Does this make working in that environment more attractive to doctors and to other clinicians?
We have found that we are getting people coming and joining us here because of the environment that we're working in. So yes, certainly from my point of view, from the staff surveys that we do, and from a recruitment and retention process, people come and want to work in an environment that supports them to deal with human beings, rather than diabetes, mental health issue, you know, a problem with your ankle. What we enjoy about our work is being able to make those connections with each other and across the whole population.
Thank you. I want to turn a bit to the rural experience because I mean, I think as I mentioned earlier, sometimes in rural communities this happens naturally, but this doesn't make it necessarily easy to bring it to fruition. Ray, I know you've done a lot of work in this, and I also know that there's some real direction from RCCBC around how this type of approach could be valuable. Can you speak to that a little bit? Just what is happening in rural medicine and the way that you're moving. I know you're the modified pentagram model and what that means.
Yeah, thanks, Jeff. And just to echo previous comments, privileged to be here. Thanks very much for the invitation. Really great to learn a little bit about the model, and it's been super interesting to see kind of the combination of a top-down and bottom-up collaborative approach. And so, yeah, I think there's lots to learn. I've learned lots kind of reading through it and certainly listening to previous presentations. So I'm joining in from the village of Valmont, which is a population of 1,100 people in Clayton some territory, kind of in the middle half of the province, there in the Rockies. You know, one of the things that really resonated with me, and I think is a tie-in to kind of the pieces, rural is not separate from the rest of the province, and Burnaby is not separate from the rest of the province. You know, very pragmatic pieces. We have a doc from Burnaby who comes out to Valmont and helps with service delivery in Valmont. I bet the citizens of Burnaby are moving all around and not always in Burnaby, not always accessing services in Burnaby. And so the importance of the connection between kind of rural and urban, and I love the description of Burnaby being kind of a Goldilocks or just right size. And I think there's a lot of truth in that. That 250,000 is actually, there's a magic number and lots to learn from the scale that you can get there. You know, for me, in the rural context, you're right, Jeff. I think not by design, but really kind of by happenstance, getting in collective community perspectives and community driving and helping shape what health looks like happens because we're small. So it's easier when you're small. But it doesn't always happen naturally, and I'll frame it. We talk a bit about gravitational pull that produces inequities that it produces, and I think we've heard lots of examples of this kind of in the conversations today around various segments of the population getting different types of service or not the type of service that they need, and that's the same thing kind of with building a collaborative approach. One of the images that came up in the slide presentation and is in your document is that of cultivating and growing, and what I would say is that there needs to be ongoing intentional effort on cultivating the fertile ground on which this collaboration and work happens. It doesn't happen naturally. And that fertile ground are not usually the things that are valued. I think we've heard lots of examples of the substrate below what's kind of on the surface, but those are things like relationship, like trust, like space. Those pieces actually, if you don't pay attention to them, certainly in rural communities, especially when you start getting stressed, then things start kind of fragmenting, and so I think that is a really important takeaway from my perspective is actually intentionally investing and recognizing that those things have intrinsic value. They're not just valuable because of what they produce, but they have intrinsic value, and it's one of the learnings we've certainly taken from a lot of our partnership with our First Nations partners kind of around this. And you know, the pragmatic of this is we've looked at, well, how do you look at creating partnerships and bringing kind of diverse perspectives into these community tables? We've taken the Partnership Pentagram Plus, a Partnership Pentagram, which is developed by the WHO for socially accountable health education. It's actually adopted by all of the medical schools in Canada. We've adapted it, as Kate was talking about, learning health systems approach into kind of a learning health systems, defining a learning community. And really added the plus. So the partners would be policymakers, health administrators, providers, citizens, the people, especially those less well served by the system, academia, so educators, learners. And the plus piece we've added is the sixth partner, which is linked sectors, industry and nonprofits, which are an important part of health and the health system in rural. And really not as a ticky box exercise, but as a bit of a lens as to who might actually be able to come to a table to talk about what is most important for us in our community. And we've had quite a bit of success with that, to the degree when we take a look at that data piece of a learning health system. We've seen, for instance, in our real-time virtual supports work, with kind of a bit of this community defining what's important, what we're going to measure, and what we're measuring, what it means. We've seen a flip of the typical model of access of services is those of higher socioeconomic status get better access. Those of lower socioeconomic status get worse access for pretty much everything. Not totally everything, but for most things. We've seen a complete flip of that for our RTVS services, where actually lower socioeconomic status kind of people have better access than higher. And so I think there are pragmatic ways to do that. One of the big things is, and I see it throughout the work that you're doing, is usually using appreciative inquiry. So looking at what, not what the problem is, but what is working and what do we want to see more of? Because however dire the situation is, there are things that are working that we can actually see more of. And then the other thing is just really intentionally look at it at scale. And I would suggest at a meso or macro scale, one of the last pieces I'd say is this idea of power as we bring in these learning communities together is super important. And particularly, I would frame it pragmatically as we've looked at creating these collective perspective tables, because like when you have policymakers coming to a table, they have a place where they can kick ideas around. If you have community coming to a table, they often don't have a place where they can actually sit and kick things around. And so we've actually intentionally started to create these collective perspective tables where these groups can figure out what is most important from their perspective and then bring it into kind of the larger table. So I'll stop there, but just, yeah, very encouraged by this work, very appreciative of everything that's been going on, and would appreciate being continue to be connected as you learn and grow, and to continue to learn from you.
Yeah, and I can guarantee that. But I think that, it's just in my conversations with Ray, some of the work that they've done around facing some of the issues around how sharing care, some of those pieces, and we may get back to this, around confidentiality, around how we actually come hand in hand around care across health and well-being, how we look at that whole person, as well as that whole piece around the processes around engagement, are tremendous places that we can learn from. I want to actually, Josh, I want to turn to you. I know that you have a strong rural advocacy, but also an experience in Hope, which really was an ability to some degree to self-determine around health needs with the support of Fraser. And I'm wondering if you can speak to that and to how that's played out and how it reflects the system that we're talking about here.
Thanks, Jeff. Happy to. On the topic of connection, which I think is so important, I wanted to ask Baljinder Narang whether her son Barinder got her a good birthday present, because it's happy birthday to her earlier this month. And so I realized that, Barinder's not always the greatest son, but I hope he has stayed connected to you. And so with that, Jeff, staying in connection, let me ask Baljinder, did she get you a good birthday present?
Can I say I was thoroughly spoiled, and I was very, very appreciative of not only my family, but also my friends and community members who reached out to wish and give me good greetings. So thank you.
Happy belated birthday for me personally, Baljinder. So
thank you
with
so
that
much.
connection point, starting from Burnaby to Boston Bar. And so Fraser Health's territory has been described as Burnaby to Boston Bar. And so Boston Bar is a small community on the far eastern part of Fraser Health. And I today am calling in from the Coast Salish territory of the Lekwungen people here in Victoria, but I've spent most of my career in the territory of the Inca Klapma and the Stolo Nation, which are also part of the Coast Salish territory. And so it's been a privilege to understand in Fraser Health, and I think, Jeff, if it wasn't said earlier, 1 in 20 Canadians live in Fraser Health, because the population means that we have about 1 in 20 Canadians. But for us in the rural areas of Fraser Health, there's only about 15,000 people. And so trying to wrestle with what is social accountability, what is connectedness, and what ultimately is hope, not just the geographical city, but also the community and what that looks like. And so, yeah, in 2016, and I think one of your lovely helpers will put this link in the Q&A or the chat, we partnered with Fraser Health to look at what we call the Hope and Health and Wellbeing Initiative, which started to look at some funding, about $500,000 a year, to do macro health investments and micro health investments. And so any community agency that had a purpose that had to be local could actually invest and apply for funding. And we did a whole series of interesting things like build trails for wellness, or started to create bus stops on some of our First Nations communities so people didn't have to stand on the highway looking at public safety. We also then invested in a series of different services. So whether that be physical therapy that didn't exist in town, some of our mental health services. And so it really was a process of true engagement where we sat in community and listened to people about what their needs were, both providers and community members, many of the partners that Ray has mentioned. I have learned a lot from Ray Markham and the RCC over the years about ensuring that there is true partnership and there is true flat conversation. So through that, we were able to, and we're now year 7 into $500,000 of funding a year, which helps support some of our services from the social network, and looking at it larger than just what I, as the physician, think we need, which is another nurse or another lab tech. What patients really want is connection. What patients want is social services, and they will much rather choose a meal over their medication if they come from a particular socioeconomic status. And so trying to reflect the kind of things we did. We built a community garden, again, so people could come get free vegetables. And then one of our local entities did some canning. And so you could actually learn to can multi-generational, intergenerational. And so it took away the conversation around health and well-being from, please let me prescribe you your Wellbutrin, to let me create an opportunity for you to connect. And so that was really micro health projects, macro health projects, and then looking at the system of care. And so Kate mentioned earlier, some of the system pressures create the kind of care that we don't want. And so fee for service. And so in addition, Jeff, to creating my working alongside Indigenous communities, the Health Authority, my local division of family practice, to do some of the hope and health and well-being. I've also in the last year been privileged to help navigate some of the Doctors of BC work, and that includes the development of the longitudinal family practice model for primary care, which has helped change the conversation for fee for service, expectedly giving people the time and opportunity to connect and build hope in patients' lives, so you don't feel like you're constantly driving towards the dollar, but you're actually connecting with the person. And so overall, the opportunity to connect, as we love to do as people, to build a macro system at provincial, national, or international level where we learn and grow from each other. And I thank you for Helen and the team being here today. And we really understand what it is to get down to the micro, which is how do we help look after people in their community, and hope long beyond my years will hopefully have been successful in doing that on a community level with local organizations.
That's great. Thank you. And it's so great to have this, we've got this example right next door that we can learn from. I do want to just pick up on that piece around connection, certainly. And Jenny, I wanted to look to you first. This is the way that we're building this system does very much reflect what's happened in Frome, both through the community connectors and through it. We're through supporting peers, and really just through the very existence of a system is a way to address isolation and create a connected community. Can you speak to how that's played out in Frome?
I think the information in the press about Frome being a town that's kind of got rid of isolation, and it's not lonely anymore, it's not actually true. It's not what we set out to do. So Dr. Kingston employed me in the beginning to create connections between what was out in the community and the GP practice. So it was all about connections. And I think for me, the bit I'm most excited about is the fact that there are amazing things out there, but so many people just don't know about them. So you can set up amazing projects and services, but if people don't know about them, they don't exist. So that's where the community connectors come in, that if everybody in Burnaby was trained as a community connector, if everybody knew that there was support out there and where to access it, that's hugely powerful. So to build that in from the very beginning, to have those people talking to each other so that we don't silo the work. Let's say you have social prescribing link workers, and actually you have to go and visit a social prescribing link worker to find out about the support that's in the community. We don't want to professionalize that. We want to take knowledge about the support that's out there back into the community where it's always sat in the past, and democratize that information again. So for me, those connections between people, knowing that information, but also becoming part of the solution themselves. So being the people who can pass on that knowledge to others is a huge gift, giving it and receiving it for themselves, but also for those community groups and services that then are found out about because of that moment of connection.
Thank you. Yeah, and I guess I look at it, and Johnny, I'm going to ask you to speak to this a moment as well, because you touched on it earlier. Simply having all of these opportunities to connect gives folks a feeling of being connected in community. That's a premise that we're working on. It makes people, and Baldev spoke to the levels of isolation felt in Burnaby, and part of it does come down to the highly diverse community we have in terms of so many different pieces. And like there was a question in the chat about can we do what happened in Frome because of this? How does this translate? And I think that the great news is we've been as Baldev mentioned, we've been working on understanding that whatever we do in Burnaby has to be able to be broadly accessible across a really broad range of economic status, of ethnicity, of ability. And so, Johnny, I just wonder, as you look at this and you talk about some of the work that you focus on, which is really overcoming isolation, how do you see these pieces, these peers and community connectors as avenues to that?
Yeah, and maybe I'll with my remarks just hover strategically for a second. Thomas Insel was the former director of the National Institute for Mental Health in the United States, and has recently solidified his whole career into 3 words around kind of the path forward, particularly for people living with mental health and substance use related health illnesses, and he describes this notion of people, place, and purpose as being incredibly foundational to moving out. And it's not to kind of negate the role of medication or cognitive behavioral therapy or evidence-based treatments, but his argument, which I really subscribe to, is so much of what recovery might look like. And I know recovery means lots of different things in different spaces, but the ability to thrive in community, regardless of whether you live with a mental health or a substance use related health problem, really is driven by our connections to place, our connections to purpose, and our connections to people. And I think the connectors model is wild. I mean, I think it's brilliant. I mean, to hear the example from our colleagues in Frome, if our success was guaranteed and we had a citizenry across all of the intersecting diversity that exists in Burnaby and beyond, that was positioned to connect people not only to formal services, but the wealth of community services. I do think those 3 Ps of purpose and place and people would really get amplified significantly. What we know, and I'll just be brief here to make space for others, what we do know is the comments made earlier, there's tremendous stigma still in raising your hand. Like, we are in a very different place now around, arguably what's been called a kind of a democratization of distress. Like, it's not, mental illness doesn't affect, if someone's living with a mental health problem myself, doesn't just affect the 1 in 5 over there who are out of sight. It really is a 5 in 5. All of us are impacted. And what we know is, peer to peer, that's where people go to help first. Like, it's easier to disclose to someone who's more akin to a peer, and to help bring visibility to services, because I really appreciate that comment. If people don't know about services, they don't exist. That's very powerful, right? So how do we bring that awareness, and of course grapple with the demand that might bring upon other services, is really key. So this model of community connection, signposting, wayfinding, from a community-centered, community-mobilized, community-driven lens, I think will help us get closer to all of the outcomes that we're describing here. So thanks for that, Jeff.
Excellent. Thank you. I appreciate it. So there's one of the Pete, and I'm going to start with Kate on this one. is around the social services, as I think we've talked about the value of the social agencies and the partnership that is critical. It's not I mean, and it is critical through all the parts. When we talk about supporting peer groups, when we talk about community connectors, we know that the social agencies will be the drivers of those solutions, that they'll need supports in order to be able to do that. But I want to drill down just a little bit just on the social prescribing piece, because it is a key element, and we talked about that universal approach. And it's so, what role do the social agencies play, and what do they need to be successful, as a partner in social prescribing? Kate, I'll start with you on that one.
Yeah, so you all have great community partners, and you probably already know many of them. And this is another opportunity to keep growing those networks. So they are one example of that community expertise that has been maybe undervalued and hasn't yet had the opportunity to really demonstrate its connectedness to health and well-being. So it's kind of a new idea for many community organizations to evaluate their work with health in mind, for example. And so that's one area where you can help. You can make those connections. Often social prescribing starts with a good community asset map where you get a sense of what's out there around you. And that includes formal and informal services, not all social services agencies, but also things like faith groups, neighborhoods, parks and playgrounds, spaces like, so those the people, place, and purpose connections that Johnny mentioned are really so vital there. So finding those connections and then really valuing that expertise. There was a question in the chat earlier about really how you do that and how you make sure that people with lived experience or community level expertise or equity knowledge are valued. And I think that is a really important thing to be considering as you're building your plans and budgets, that this is expertise that otherwise we don't have. And so there's something that community members have when it comes to, for example, building trust relationships with people who have, strong historic and contemporary reasons to mistrust healthcare, for example. This is where a community organization can really help, or where a peer worker who comes from the community can really help. So as we're growing and systematizing that knitting together of community work and health through social prescribing, one thing that we really value is having that connector role or link worker role be played by a peer, a community health worker. It doesn't need to be somebody with clinical training, because these are communities that have maybe faced some barriers to accessing that kind of clinical training. What's really needed is the trust, the ability to listen really deeply, to see the person as a whole person in the context of place, people, and purpose, and to walk alongside them as they make decisions for themselves, and connect into those community organizations. So when you're thinking about evaluating your work, for example, you want to think about, are we moving that quintuple aim for healthcare of quality improvement, population health, health equity, and so on, but also, are we transferring resources into community? How are we doing that? Are we putting our money where our mouths are and really giving money to the community organizations to make sure they can handle what might be a big uptake in services? Or are we situating a link worker or community connector in a community agency or organization? Are we making sure that we're paying people for their time when they come to the collective perspective table, which I love, right? Like, are we giving people the supports they need to be there? Financial time, training, peers around them, all those kinds of things that give us a sense of belonging. So those are all really ones that are really important in building community self-determination in health. And, we've got tons of amazing leadership from Indigenous health leaders on what that looks like for people in communities. And it's important for all of us that we have a health system that really recognizes our autonomy to make decisions for ourselves, our competence, that we've got something to offer, our relatedness, which has come up so much here in that sense of belonging and community, and our ability to give back, our beneficence. Those are the components of self-determination individually and collectively that really matter. And so if we're starting to really see people as whole people who can contribute, that's the way we're going to really move that and make that happen. And so, as I think many of of you have mentioned, taking that strengths-based approach and that appreciative inquiry approach allows you to say, a lot of this is happening in our community, and what we're trying to do now is really systematize it so that it's equitably available and that we can keep learning and improving.
Thank you. That's great. Well, it's amazingly we're coming to the end of our time. What a great discussion. I want to round back just for a last comment. I'm going to come back to where I started, which is with Baldev, who's been here for sort of since the outset, I guess. And can you just to close, Baldev, can you tell us the reasons that you believe that Burnaby is so well positioned to actually move forward and realize this? Why do you think this can actually happen?
So, I mean, you've heard it today already that we're like the Goldilocks community, not too big, not too small, just right. And I think all of us that live in Burnaby see that, feel that. And those of us that have some connection to other folks around us have definitely bought into and drunk the Kool-Aid, so to speak, right? So we're definitely into that whole piece about engaging with each other. And since the Division of Family Practice has been in place, we've been engaging with the physician community quite well, and that's since 2010. And we've been building and building and building, and each moment of adversity that comes our way enables us to dig a little bit deeper and come up with even more connectiveness. The pandemic has been, as nasty as it has been for some people, it's actually spurred us to be more collaborative, be more together, bringing and willing to share our assets that we have, that we control. We have certainly set up an engaged spectrum of local partners. We've created a governance structure that brings our PCN is unique. We have a tripartite co-chair system. Nobody else has that. We trust. Ministry of Health is given us directive. FPSC has given a directive to think about having a governance change where the physicians are leading the PCN, and we've actually chosen to continue with our tripartite structure because we feel that it's important to maintain that connection back to the community and have access to information and support from all of the social agencies that we wouldn't have otherwise, and we wouldn't get that lens, the trauma-informed lens that it's so important to bring to the table when we're looking at problems and trying to solution. It's enabled that, and we've maintained effective communications. We've built social capital and trust from having shared goals that we've had lengthy discussions about what are our shared goals, what do we want to do, and just working together in the trenches in various different aspects, and being involved in the community has enabled that. And I can say for sure that Burnaby's definitely the Goldilocks community, and I'm here to stay. I'm not going anywhere else, and we will keep pushing. The ability to engage with each other has also meant that we understand what our collective responsibility is. As you said early on, we've accepted the fact that this is the problems that we feel, that we field every day are not my problems. They're not your problems, but rather they're our collective problems. And the solutions and everything that comes out of that collective responsibility will be impacted by all of our different partners, because they all hold different levers that will impact the problem and the solution in different ways. And I may see a lever in somebody else's hand that I need to pull, and then I need to engage with that group, that person, and enable them to do the work that they can do. And so that's where we need to continue working. We do. I see my role, and most of us family physicians in Burnaby see our role in this collective responsibility system to see our patients' needs and then find the best partners in our group team to be able to address our problem for our patients and community. while we still maintain privacy and confidentiality for the patients. We do need some further discussion around data collection, data management, and all that stuff, but nothing that's not insurmountable. These are, again, difficult, tough conversations that we're all adults here. We can have these conversations.
Great. Thank you. That's excellent. Well, thank you. I just want to thank everyone on the panel for coming to the panel and being such great voices on the panel. But also, I think each of you have indicated that you'd love to continue to be attached to this work, and we'd love to have you to continue to be attached to this work. It's tremendously appreciated. So thank you for your time. I hope to see you again in the near future. I know some of you have to leave, but if the others would like to stay for the rest, of course, you're welcome to do so. We don't have coffee or tea. I apologize.